Good afternoon to everyone, and thank you to be here to this new chapter of the Earner Connect educational webinars. And today we will discuss on osteoporosis with our two guest speakers that are Prof. Sabrina Paolino and Dr. Giovanni Adami. Prof. Sabrina Paolino is an associate professor in rheumatology at the University of Genova in Italy and a member of Earner Connect. She is head of the clinic dedicated to the management and to the therapy of osteoporosis in our clinic and in Genova, and her fields of interest are the biological functions of vitamin D in rheumatic diseases and the bone metabolism in rheumatoid arthritis and in rare and complex connective tissue diseases. She will present the first part of this presentation, discussing the epidemiology and the pathophysiological mechanism of osteoporosis in autoimmune connective tissue diseases with specific clinical imaging features. So the second guest speaker will be Dr. Giovanni Adami, who is an assistant professor in rheumatology at the University of Verona in Italy. He has been a postdoctoral fellow at the University of Alabama at Birmingham in the United States, and he is one of the most talented young researchers in the field of osteoporosis, co-author of the module on osteoporosis in the EULAR online course on rheumatic diseases, and the convener of a new ongoing EULAR project for the development of the recommendation on screening and management of osteoporosis in inflammatory rheumatic musculoskeletal diseases. He will discuss advanced and coming treatment options for managing osteoporosis in the second part of the presentation. And I would like to remind to the audience to write the questions in the question and answer box or in the chat, and that the speaker will address them at the end of the presentation. So I have already taken up too much time, and I will invite Sabrina to share her screen and start the discussion. Thank you.
Thank you, and good afternoon, everyone. I present today my presentation regarding the mechanism and the specific clinical feature of osteoporosis in rare and complex tissue disease. So what is osteoporosis? Osteoporosis is a skeletal disease characterized by low bone mass, so is a defect of bone quantity, and the altered bone microarchitecture, so a defect of bone quality, with an increased risk of a fracture. By mechanical point of view, the increased risk of fracture is related to the variation of bone strength, so bone resistance, due to modification in bone mineral density and in qualitative alteration in geometry and microarchitecture of the bone. During the course of the life, we assist of different phenomena that involve the skeletal. First one, the first mechanism is among modeling, the process in which bone are shaped or reshaped and defined the skeletal development and the growth of the skeleton, as you can see in this picture. In the second part, we assist to the bone remodeling, that is a process that was very articulated and in which osteoclast and osteoblast work in the sequence to achieve a correct equilibrium in a single bone remodeling unit. Also, bone remodeling is very important to achieve, to create a peak of bone mass that is around 25 years old. So it's very important because achieve a high peak of bone mass during the growth has a role in the future risk of fracture when the people are very aging and very old. Generally, in normal condition, bone remodeling is a coupled process in which bone resorption is in perfect equilibrium with bone formation. But a multitude of factors influence bone remodeling. Some are protective, some are detrimental on the matrix and also on the cellular bone. This factor is very important to achieve the first peak of bone mass we can see in the first slide, but also to maintain the quality and the quantity of bone mass during the life of the patient. When these factors that are very different stimulate bone resorption over the bone formation, bone remodeling equilibrium break. So we assist to bone loss and so the osteoporosis. There are different mechanisms that are implicated in primary and secondary osteoporosis. In primary osteoporosis, that is a pathophysiological condition relating to menopause or to senescence. We have some genetics mechanism and some other mechanisms that are related to lifestyle of the people. But in the secondary osteoporosis, we had some other important mechanisms that are related to disease and also related to the treatment that patient use for treat your disease. So in rare and complex connective tissue disease, we have in the area of the secondary osteoporosis. Osteoporosis, in fact, is a major comorbidity in rare and complex connective tissue disease, and there are different mechanisms and different types of complex and rare connective tissue disease that are related by disease, by treatment and its effect, and also by the basic lifestyle factor that the patient has in your habits. So the secondary osteoporosis in hereditary rare connective tissue disease, as reported in this important meta-analysis, underline the very important risk of bone fragility in this kind of patient related principally to mechanism related to genetic mechanism, because genetic factors influence the achievement of peak of bone mass. These are pediatric diseases, so related to genetic basis, particularly mutation of collagens. So there are some defect in matrix of bone. Particularly this is in osteogenesis imperfecta, in which some paper underline the importance of the disorder of bone quantity, but also in reduce of trabecular and cortical thickness. So there is also a bone quality defect in this kind of disease. Different are the mechanisms that are represented in rare complex connective tissue disease, in which osteoporosis is related to the modifiable and not unmodifiable patient characteristics, so lifestyle or age, but other mechanisms are related to disease. So, for example, the chronic inflammation, the glucocorticoids therapy, the hormonal and vascular factors, or the vitamin D deficiency. Chronic inflammation has an action direct on osteoblast and osteoclast. Pro-inflammatory cytokine increase bone resorption, acting on osteoclast and reduce osteoblast function, impairing so bone formation. So there is a sort of immunoporosis in this kind of disease. So physical inactivity that are typical of some of symptoms of this disease, for example, due to arthritis, myositis, pain, fatigue, reduce the mechanical loading of the bones. So the bone are in defect of mechanism to sustain its activity. For example, sclerostin, that is an inhibitor of Wnt signaling, increase during prolonged immobility. So reduce bone mass related to little activity of osteoblast. Hormonal factor, vascular factor are very important in connective tissue disease. Some patients, for example, lupus patients, are a premature ovarian failure due to the use of gonadotoxic therapy, or the macrovascular damage that characterize renal phenomenon in systemic sclerosis induce hypoxia, so affecting consequently the bone metabolism. And the last, the vitamin D deficiency is a characteristic of typical connective tissue disease, for example, in systemic lupus erythematosus, in which this kind of patient reduce your exposure to the sun and so on. There is a reduction on vitamin D production. In some other kind of patient, for example, in systemic sclerosis, on overlap syndrome, in which there is malabsorption, in which is very difficult to achieve a very correct level of vitamin D. This combination of multiple factors are different in different type of connective tissue disease. In some, for example, in systemic lupus sclerosis, as we can see in the previous slide, we have deficiency of vitamin D, also for renal disease that is associated of this kind of disease, glucocorticoid use, or premature menopause. In systemic sclerosis, we underline the importance of malnutrition, malabsorption, and so in vascular changes. For example, in inflammatory myopathy, for example, dermatomyositis or polymyositis, in which patients are very difficult to achieve the activity, regular activity every day. So there is a reduced activity and very high dose of glucocorticoids. Now, it's very important to underline how to assess the fragility and the risk of fracture, how to estimation the fracture risk in this kind of patient. What is now, today, the role of densitometry? Generally, the low bone mineral density is a strong predictor of fragility factor, but 80% of patients experience a fracture when T-score is in the range of osteopenia and not in osteoporosis. So fracture occur independently of DEXA values. This is very important in connective tissue disease. For example, in lupus patient, the high incidence of fragility fracture arrive in an area that is above the diagnostic threshold of osteoporosis. So indicate that BMD alone is insufficient for identify high-risk patients. So the fracture risk is very complex, and fracture risks, consequently, the bone strength depend not only on bone mass, but also on bone quality. So it's important to include BMD evaluation by densitometry, but there is not only the only measurement that we can do. So it's important to evaluate the risk fracture by calculator, for example, for the FRAX, but it's very important to use FRAX adjusted for TBS. What is TBS? TBS is a new tool to assess the bone quality. TBS is a mechanism using the same evaluation by densitometry in the area of the lumbar spine to evaluate to detect the bone microarchitecture. So some studies confirm the utility to discriminate osteoporosis in autoimmune rheumatic disease, particularly in connective tissue disease, for example, systemic sclerosis or lupus, to use trabecular bone score. And why trabecular bone score is so sensitive and rare and complex connective tissue disease? Because trabecular bone, differently to the cortical bone, is metabolically more active with a faster turnover rate, so is more sensitive to inflammatory and hormonal stimuli. And the last, what is the effect of anti-rheumatic drug we use to control the disease? We use generally to control inflammatory disease, and particularly complex tissue disease, two lines of therapy, principally two lines of therapy. The anti-rheumatic drugs or disease-modifying drug that has a positive effect on bone because are very important control of inflammatory mechanisms. And the other line, there is a glucocorticoid therapy. Glucocorticoid therapy are some effects that are positive and some other that are negative. So depend on the time-related effect and dose-related effect. What is the significance of two affirmation? Effect of time-related effect on glucocorticoids depend in the two phases. In the first phase, early phase, in the first, here we use glucocorticoids, we have bone loss equivalent to 6 or 12%. In the second part, in the long-term use of glucocorticoids, we have 3% bone loss every year. So the time effect are related to two mechanisms. In the first phase, in the early phase, we have an increase of osteoclastogenesis. In the second and longer-term phases, we have a very important effect to inhibition of osteoblastogenesis. The other very important mechanism to underline is the dosage of the use of glucocorticoids. We can see that the BMD decrease in relation to dosage in different manner. If you have a dosage upper than 5 milligram daily of prednisone equivalent, we have 4% of reduction in BMD, but when you use a low dose of glucocorticoids, the BMD loss is reduced. So fracture risk increase after every dosage increase of dosage of glucocorticoids for dosage upper than 5 milligram daily prednisone. So the is important your attention to note that low dose of glucocorticoids under 5 milligram day is not related, not associated with elevated reduction of BMD. So use glucocorticoid in very low dosage. Finally, to note that as reported for mechanisms that are that characterize autoimmunity and inflammatory, we can see also for glucocorticoids a direct effect on microarchitecture. So it's very important is in group of patients to use densitometry to capture not only bone mineral density, but also the TDS. So evaluating in patients we use glucocorticoids, bone quality, then bone quantity. Finally, to conclude, what is the approach to optimizing bone health in this kind of patient? The management strategy is very complex and is important to encourage patients to safe lifestyle, increase, for example, is possible physical activity, optimize calcium and vitamin D intake, monitoring regularly densitometry, using evaluation BMD quantity and using trabecular bone score to evaluation the quality of bone. Pharmacological management, minimal use of glucocorticoids in low dose and short duration, and work to achieve remission of the disease with better control of inflammation. Thank you for your attention.
Okay. Should I start my presentation now? I think so. Thanks. Thanks for the very kind introduction. Thanks for the organizer for inviting me. I don't know if you can see my screen right now, but anyway, I'm gonna talk about very briefly about the osteoporosis treatment in connective tissue diseases. So basically, Sabrina told us about the pathogenesis, the mechanism underlying the development of osteoporosis and bone loss in connective tissue diseases. I'm gonna touch a little bit on the possible treatments and pharmacological treatments that we can use, and how we can differentiate these treatments from postmenopausal osteoporosis. Obviously, most of these pharmacological agents, medicines, were tested largely in postmenopausal osteoporosis, but people started to use in connective tissue diseases, in rare diseases, in inflammatory diseases, and I will try to show you that there might be some differences between postmenopausal osteoporosis and other diseases. These are my disclosure. And first of all, I need to disclose, I will be very, very sorry about that, but I need to cherry pick some of the information that I will give you today. We'll need to select some of these. We have many connective tissue diseases, as Sabrina showed us, but we have a limited time to discuss, and so basically I will touch on very few of them. And what are the three big ones? Well, first of all, the collagen-related diseases, so rare genetic diseases that affect collagen. And so basically the quality of the bone and the quality of the structure of the bone, and not the mineralization itself, not the bone density itself. It's a secondary mechanism, but the main is related to the collagen defect. The second is glucocorticoids. Sabrina showed us that glucocorticoids, even in the minimal amounts of dose, can induce bone loss, and more importantly, can affect fracture risk. Even if they don't affect bone loss, they can increase fracture risk. And third of all, the last but not the least, the inflammatory rheumatic musculoskeletal diseases. So basically, how inflammation affects and how can we treat those patients effectively for their osteoporosis. First of all, collagen diseases are a wide range of diseases. We have Ehlers-Danlos, we have many genetic conditions, but we can use osteogenesis imperfecta as the prototype for collagen defect. So because it's quite common, it's not a very rare disease. Type 1 is probably underdiagnosed worldwide, and so it's probably less than 1 out of 2,000, and it's a very prototype of fracture risk, increased fracture risk by decreasing the quality of the bone. But we also know that increasing bone density is associated with decreasing fracture risk. So basically, BND is the main predictor of fracture risk, but we have a disease in which the quality is affected. So can we really use these drugs to treat effectively the fracture risk in osteoporosis? Well, the answer is quite easy to show, and is very briefly can be very briefly explained by this cartoon. This has been in a large cohort of osteogenesis imperfecta patients, the site of the fractures in patient not treated with bisphosphonate, which represents, by the way, the gold standard of treatment for osteogenesis imperfecta. And as you can see, they have a wide distribution across the femur, but more importantly, they are distributed across sites that are considered not typical. So basically, fractures in osteogenesis imperfecta, atypical fractures in osteogenesis imperfecta are quite typical. So you should never mention atypical fractures in osteogenesis, because in those patients, those fractures are quite typical. And if you treat those patients with bisphosphonate, you can see that you can reduce the fractures happening at the typical sites, so very proximal, so the femoral head, the femoral neck, and you can reduce the distal fracture, so epiphyseal fracture, but you cannot reduce those fractures that are associated with something different, that are associated with decreasing bone quality. This is partially related also to these affected quality, affected radius of the osteogenesis imperfecta patients. And this is a very basic concept for mechanics, for engineering. So basically, the larger the radius of your structure of a tube, the higher is the bending capacity and resistant to the fractures. So basically, the outer radius is more important than the inner radius. That means that if you have a larger bone as compared to a thinner bone at the same density, you will have higher resistance with a larger bone. So it's more important having a structure of the bone. That is very easily explained by the cross-sectional moment of inertia. So basically, same density, but larger bone is better to have a larger bone. And what is new? What can be really done to increase bone quality and increase bone density at the same time to improve both, to reduce typical and what we know as atypical fractures, so more osteogenesis imperfecta related fractures. Well, we have new drugs on the pipeline. This is the very remarkable results of the setrusumab study. Setrusumab, as you might know, is a anti-sclerostin antibody that has been tested. This is the phase 2b asteroid study of setrusumab, and the phase 3 is ongoing. We will probably have the results next year. But here in adults patients, you can see the lumbar spine is increasing quite consistently, very similar to the postmenopausal osteoporosis. You might know that romosozumab is another sclerostin inhibitor approved for the treatment of postmenopausal osteoporosis. But here in osteogenesis imperfecta, what is even more interesting is that the stiffness and the failure load at the radius is increasing over the time significantly, especially with a higher dose of setrusumab. So basically, the therapeutic dose of the setrusumab. So basically, it can increase the lumbar spine and more than bisphosphonates, which is quite important for most of the fractures. But even more importantly, even more, let's say, even more innovative, it can increase HRPQCT parameters like stiffness and failure load at the radius, a site that is quite difficult to improve and is quite susceptible to fractures in patients with osteogenesis imperfecta. And what about fractures? Here we have one of the study from a phase 2-3 orbit study. So those were patients, younger patients, pediatric patients. As you can see, it can reduce the number of fractures. So it's basically the primary outcome here was one of the outcomes here was the annualized fracture rate, and it decreased by 70%. And so what's absolutely stunning results for just 12 months of study. As you can see, they tend to fracture once a year on average. So it means that those patients had every year they had a fracture while before entering the study. After the study, they had 0. So basically, they annualized the fracture rate and they tended to be 70%, but it's quite pessimistic because it might be even more. So those patients did not fracture. And so this is what is new, really, very briefly, because we have a very, very short time to discuss. We can discuss later on in the discussion, but then we will very briefly touch about glucocorticoids. And so why is glucocorticoids a big problem? Well, Sabrina told us again, but one of the main issues is that we are still using chronically glucocorticoids at doses that are widely considered as not safe for the bone. both for the bone mineral density, both for bone quality and fracture incidence. So basically, we are using too much glucocorticoids. This is an Italian picture that we took in 2024. And what is new on glucocorticoids induced osteoporosis? Again, the sclerostin inhibitors might show very promise. And what is even more interesting is that romosozumab, a sclerostin inhibitor, as you can see from its mechanism of action, it can increase bone formation and decrease bone resorption. So it's basically the perfect drug you can think of in a very early phases of glucocorticoid-induced osteoporosis. In the very early phases, we have an increase in osteoclast activity and a decrease in osteoblast activity. So it might be a perfect drug. It might work very, very good. We have preclinical data showing that romosozumab sclerostin inhibition might work very efficiently in preventing glucocorticoid-induced osteoporosis. But now we have finally the first randomized controlled trial of romosozumab versus denosumab, which, by the way, is a very effective drug in glucocorticoid-induced osteoporosis, proved by many clinical trials, even against bisphosphonate. And the results were very encouraging, especially on lumbar spine BNV, as expected. But basically, in glucocorticoid-induced osteoporosis, in patients that have received a lot of glucocorticoids before entering the study, so 2 grams on average. So they were even not the best candidate for romosozumab, but even in those patients, difficult situation, very hard competitor, denosumab, very effective drug. Well, romosozumab proved to be more efficacious on lumbar spine DMD and also in trabecular bone score. What is even more interesting, smaller study, is that this small randomized trial prospective study that was presented at Euler last year and showing remarkably, not very remarkably, I would tell, but very, very similar results. So romosozumab being more effective than denosumab, which was more effective than risedronate and bisphosphonates on lumbar spine. Conflicting results on femoral neck totally. This might be related to the population, which was heavily treated. They did not withdraw glucocorticoids. That was quite a unique population. We might have time to discuss that. But at the end, last but not least, the inflammatory rheumatic musculoskeletal diseases. Again, we have 1,000 mechanisms going on in inflammatory diseases. We have negative effects of glucocorticoids, active inflammation itself that is just a negative effect on bone. So we have a complex interaction of these mechanisms. And by the way, the outcome is quite easy to understand. It's fractures. So these patients tend to fracture, and they tend to fracture independently from glucocorticoids, from family history, prevalent fragility fractures, BMI, and BMD, which is quite important. And some of these diseases might be even more prone to fracture, like rheumatoid arthritis is more at risk than psoriatic arthritis, or neurological diseases by their impairment might be even higher risk. But by the way, all pulled together, all inflammatory diseases have an increased risk. And what is new is that this risk has been recognized by Euler, which has funded this initiative. This is the steering committee. There's a very large task force from Euler, and basically we are developing this. The process is ongoing. We are conducting the SLR right now on the screening and management of osteoporosis in patients with inflammatory rheumatic musculoskeletal diseases. So it's that important that might deserve a recommendation set from Euler. And why is that important? Because there are specific mechanism of inflammatory rheumatic musculoskeletal diseases that lead to development of osteoporosis. There are many: inflammation, CCP antibodies, so basically ACPA, rheumatoid factors, low exposure to vitamin D, whatever you can think of. Sabrina outlined very brilliantly on that. But there are many other metabolic factors at the play. One of these is DKK1. Was a seminal paper by the group of Gerichet showing that DKK1 is the master regulator of joint remodeling. And you might know that DKK1 is the first cousin of sclerostin. So it's basically the two Wnt inhibitor. They both regulate very tightly, very in coordination with between the two, the bone metabolism in patient with rheumatoid arthritis and in postmenopausal osteoporosis. And why is that important? Because we have drugs that might act on bone remodeling, on evolution of rheumatoid arthritis, erosion, and like the denosumab showing here in this very important study, randomized double-blind phase 3 study on denosumab in erosions and in fracture risk in rheumatoid arthritis, that might act actually on DKK1. And that has been shown in many conditions. In postmenopausal osteoporosis by our group, we show that DKK1 is constantly reduced in postmenopausal osteoporosis treated with denosumab. And this might be one of the possible explanations of this special efficacy on some type of diseases like cancer or multiple myeloma or in breast cancer metastases or skeletal related events. So it's basically by decreasing DKK1, denosumab can increase bone mineral density on the long run, so inducing modeling-based bone formation, and possibly can have some metabolic effect on rheumatoid arthritis and in some other very erosive diseases like multiple myeloma. Why is that important on the Wnt system in rheumatoid arthritis, especially in rheumatoid arthritis? Because this study showed us that ROMO might be less effective in rheumatoid arthritis as compared to non-rheumatoid arthritis. To show here that the response in P1 and P was attenuated, was shorter, the anabolic window was smaller, and the change in lumbar spine and total lip was lower in this matched cohort of rheumatoid arthritis and non-rheumatoid arthritis patients. By the way, to be honest, this is a remarkable increase in lumbar spine BND, as you can see here at 12 months in rheumatoid arthritis patient, which respond less well. The increase was about 9%, so remarkable increase. Why is that? Well, we very recently published just a couple of months ago this analysis, this study. We tested how does DKK1 behave during treatment with romosozumab. And we, not surprisingly, by the way, because some animal studies show that, and then other studies on sclerosis showed very similar results, but basically this is the first observation in romosozumab patients. DKK1 increased, and paralleled the increase, the decrease in P1 and P serum levels, so the anabolic effect of P1 and P. So basically, DKK1 might be a negative response to the romosozumab. So you inhibit sclerostin, and the first cousin came up and says, "No, I wanna reduce this anabolic." Might be a protective effect. It might be have a role in protecting too much bone to build up, and you might think, "Oh, well, I can try inhibiting both. Why is not a dual inhibitor on the market right now?" Well, if you think that someone else might have thought of that prior to you, and actually Amgen did develop a bispecific antibody. It was developed back in the many years ago, more than 10 years ago, and it showed very promising results, more in mice, more than the sclerostin antibody or the DKK1 antibody alone. So basically, inhibiting both might be a very promising treatment approach in osteoporosis. And by the way, we have now a novel dual inhibitor developed by Angitia, and a new company on the market, that has been testing in a phase 1 and phase 2, and now is starting the phase 3 clinical trial in the United States and all over the world on a B-specific antibody. And those are the remarkable increase that these drugs did in human beings. Those were healthy volunteers. Keep in mind, healthy volunteers, most of these were male, and this one was in postmenopausal women, sorry. And so basically, the BND increased by a stunning 12% within just 6 months of treatment. And by the way, they administered at 0, 30, and 60 days. So just 3 subcutaneous injection plus 12% at 6 months. So it's basically the results you might see with romosozumab 1 year, and they had achieved that in 6 months with just 3 injection in patient with a quite not very decreased bone mineral density. So in conclusion, the Wnt system is the key regulator of bone metabolism, and more importantly, we can target it. We can target it with several drugs. We have setrusumab on the pipeline for osteogenesis imperfecta. We have romosozumab just reimbursed all over the world for postmenopausal osteoporosis. And we probably will have a new DKK1 sclerostin dual inhibitor that might represent the future of the treatment of osteoporosis. Thank you.
Thank you very much for both presentations that were totally complementary. And even the presentation of Sabrina was an introduction and offered targets for the therapy of Giovanni Adami, and to explain much better. I think now that we should have some questions for both of you. I would start with Sabrina, and that you suggested to do the combined evaluation of DEXA and TBS. But in present osteoporosis, the frequency to evaluate the status, quality and quantity of the bone, in your experience or following the literature, how much frequent should be when, of course, start the treatment? What do you expect to do?
Yeah, thank you for the question. Generally, we use to test densitometry, the densitometry to evaluate the bone quality and bone quantity every 18 months as a guideline. But in my experience, and also in experience of a patient with a particular kind of disease, such as inflammatory disease, probably every year, if the patient have a very high risk, to modulate also the therapy and modulate the effect of the therapy, disease modifying, and also therapy to evaluate, to control the bone loss. So is depend on the postmenopausal patient or secondary osteoporosis that are a particular group of patients in which strict control is very important. So not only every 18, 24 months, but probably one a year.
This is an interesting question, because another question was exactly linked to this one. Considering postmenopausal senile osteoporosis, again, you suggest different approach in evaluating the status of the bone outside the connective tissue disease, inflammatory diseases.
Also in postmenopausal people, or in people, senior people with primary osteoporosis, is important to evaluate the quality, because the quality, as Giovanni speak very well, is very important to control also by the therapy, because we have now some mechanism, Wnt inhibitors and also RANK inhibitor, that are very important to control quality of bone. So also in postmenopausal people, in my opinion, is very important to test BMD and also TBS if possible, to better control the risk of fracture by FRAX, generally in European and American people, and in Italian by DEFRA, that is a particular risk of score dedicated for Italian people.
Thank you very much. Now a question for Professor Adami that I see is we know that prolonged use of biphosphonate may paradoxically increase the risk of fracture. Is this true also in osteogenesis imperfecta? If we start biphosphonate, paradoxically, after some time, we can increase instead of reduce the risk of fracture or not? Are there information about that?
Well, that's related obviously to the slides that I showed on where and how does these patients fracture. So basically, atypical fractures in osteogenesis imperfecta patient are typical fractures. And so you might have this paradoxical increase in atypical femoral fractures, but those are not truly an increase. This is just bisphosphonate not working on these type of fractures, because those are related to the structure of the bone, the quality of the collagen, the dimension of the diathesis, and so on. Said that, we know that probably prolonged treatment with bisphosphonate is does not give an additional benefit to our patients, even if they are osteogenesis imperfecta or postmenopausal osteoporosis patients, because the bisphosphonate have a very prolonged skeletal retention. They have a plateau effect on bone mineral density. So building up bones is not their aim. They just conserve what has been built before. And so basically, my approach to osteogenesis imperfecta patient is that I usually do not treat them if they are low risk when they are adults patients. So in between the puberty from 40 to 45 years old in osteogenesis imperfecta type 1. I monitor the CTX and monitor the DEXA, but if they lay on osteopenic levels and they do not have fractures, we just suspend. This is the honeymoon for osteogenesis imperfecta, but most of the time, after the age of 50 and after the menopause in female, we restart the treatment, monitoring the CTX, keeping the CTX suppressed, but not as much as you to increase possibly
the risk.
We don't know the fracture risk.
Here we have a question that I would like to have an answer for both of you. The question is, osteoporosis in inflammatory rheumatic disease is clearly multifactorial, and each inflammatory rheumatic disease is unique in the weight of different risk factors. Do you think that current fracture risk calculators are efficient enough at capturing the real risk of fragility fracture in patients with IRMDS, or how should a new tool be developed? Sabrina, and then Giovanni, please.
Okay, as previously, I think that a new tool has to develop, because now we use generally FRAX calculator, and FRAX calculator have some limits. For example, not include the use of the therapy in secondary osteoporosis, for example, glucocorticoids, the dosage of glucocorticoids, how long the patient take glucocorticoids, if the patient use to supplement vitamin D, the dosage of supplements, the supplement of calcium. So this is not very complete to evaluate the single risk factor particularly in secondary osteoporosis. So is to prepare now scientific society are to work to implement the tool to evaluate better evaluate the risk of threat. In Italian, we have the EFRA calculator that is more sensitivity of fracture calculator and include some of these risk of factor, but probably the tool are to better increase and better evaluate this, in my opinion, and in generally research opinion.
Thank you. Please, Giovanni.
I agree. Yeah, obviously I agree. There's some lack of sensitivity in this very particular population, especially because fracture risk assessment tool rely on most of the fracture risk relies on BND, and BND might not be the best outcome or the best surrogate for fracture risk in these patients. But you know, we need to handle the complexity and precision and accuracy of a fracture risk algorithm. You know, you might want to include thousands of clinical risk factors to have the perfect algorithm, but we only have 20 minutes for seeing the patients. So the complexity and the balance between the complexity and the precision of the algorithm is crucial. Perhaps machine learning algorithms and artificial intelligence might help, you know, digesting the complexity behind fracture risk assessment tools, so including disease activity, including CRP, including whatever you can think of that might be associated with fracture risk.
Here there is a question a little complex because ask about osteoporosis in Ehlers-Danlos syndromes. We know there are 13 syndromes with totally different clinical aspects, but there are some aspects in common, and the sufferance of the bone is one of these, together with skin fragility. So what can you say about the Ehlers-Danlos syndromes, please? Sabrina, if you to say, or Giovanni, or both, much better.
As reported in my presentation, we now know what are probably the mechanism, because there are a genetic pathology, so there are some genetic alteration to creation of the collagens, so is a particular risk to the composition of matrix of bone. So patients that are very strictly considering, very strictly control with quality of bone, so are the typical patient to evaluate the TBS, for example, this kind of patient. But many other information are not today to the complexity of the pathology. So this is a genetic pathology with the genetic mechanism. So I surveillance to the mechanism and the control of the quality of bone, I think.
Okay, Giovanni, please.
Yeah. Oh, so basically, what can we briefly say about Ehlers-Danlos is that we translate evidence from osteogenesis imperfecta to other connective tissue diseases and collagen diseases. So basically, randomized control trials have been done in osteogenesis imperfecta, very few in other collagen diseases. So basically, we just treat as we treat osteoporosis, osteogenesis imperfecta. So my clinical approach, very practical, is that if the patient has multiple repeated fractures, so the biggest problem in these particular patient is skeletal fractures and not hyperlaxity or whatever, well, I treat them exactly as I treat osteogenesis imperfecta. So the same approach, honeymoon, bone anabolic if needed, and so on.
Yeah. And last question, but from me. You mentioned sclerostin as a very important inhibitor of sclerostin, a very important approach. You say that probably is one of the main target to consider. But when we can say start with inhibitor, we can evaluate a biomarker in the patient, and so based on the levels of biomarker to decide compared to other approaches. Thank you.
Oh, well, basically, we might have some biomarkers, you know, those are being studied. The sclerostin levels at baseline might be associated with the response of sclerostin itself. Estrogen levels might be associated with the response of sclerostin. But the most important is the clinical factors is have been treated with a bisphosphonate or being naive patients. So pre-treated patients tend to respond less to every anabolic drugs, bone anabolics, dual inhibitor, the sclerostin inhibitors, or abaloparatide, teriparatide. They tend to respond less to in patients previously exposed to bisphosphonate, and that is very quite easily answered. This less response is very easily explained by the remodeling unit. So how does the bone work? So basically, if you have a closed remodeling unit, you don't have many osteoblasts to stimulate on, to stimulate the overflow modeling bone formation. So basically, the increase in anabolic osteoblastic activity within the remodeling units. And so you're losing part of the efficacy of the drugs. We can also say that there are accumulating evidence that sclerostin inhibitors might be less affected by this mechanism as compared to abaloparatide and teriparatide. So basically, in pre-treated patient, sclerostin inhibitor might perform better than PTH analogs.
Okay, so I think our time is finished. Let me see. No further question. So thank you first, Sabrina, for your wonderful introduction update, and thank you, Giovanni, really, because you really also updating the new therapies that we are continually searching for the approach much more targeting and personalizing the therapy to the single patient. So here, osteoporosis that once was considered one form, now we see we have several osteoporosis, and maybe we should think about how personalize the osteoporotic patient. Thank you again. Thank you, Emanuele, for the co-moderation, and see you soon. Thank you very much.
Thank you.
Thank you.
Bye.
Bye. Thank you.